Good afternoon, ladies and gentlemen, Mr. Chairman. I'm actually a fellow at the Cleveland Clinic, but managed to arrange an escape up to exotic Quebec City and spent 10 weeks there with exposure to bariatric surgery. And was fortunate enough to be involved in this project and to be able to report on it today. I have no disclosures. Now, I'm going to skip past the general overview for the sake of time and focus directly on the technology in what is involved. As many of us are aware, obesity is a problem, and this is a particularly exciting time to be in this space and to report on this rather promising intervention. What it involves is an endoluminal approach to weight loss, and it's basically a completely endoscopic procedure performed through an endogastric tube. As you can see in the image, there's a tube with a 5-millimeter endoscope being passed through to allow us to achieve the restrictive component of this procedure. And basically, it involves making a full through-and-through plication in the cardia below the GE junction and attaching anchors through which a restrictive umbrella, if you will be attached. And as you can see from the image in the right hand side of the slide, it has 5 anchoring points, and the restrictive element is attached to that. We were able to do this in basically a phase 1 clinical trial to assess the safety of this procedure. Background work was done in animals, but I'm here to report on our experience in a randomized 2-arm study where patients were divided into 2 groups. And basically, one group of patients had the anchors implanted at time point A, and then 6 to 8 weeks later, at time point B, they ended up having the restrictor device. The other group, of course, had both the anchors and the restrictor at the same time point. The patient selection basically involved following NIH criteria or guidelines for bariatric surgery. They had to be categorized as morbidly obese. Maximal BMI accepted for the study is 50, and patients were generally under the age of 50 as well. They had to have no hiatal hernia, and they would go through an extensive psychiatric and nutritional evaluation. Demographic data is as follows. We had a sample size of 12. The average age is 39 with the spread seen in brackets. The ratio of males to females was 1 to 3 in the study, and the preoperative BMI was around 43 or 44. There was no difference between the 2 arms, by the way. The initial mean weight is 122 kilograms, and the number of patients that went through the single-stage procedure was 7, and the number that had the 2-stage was 5. This is a video of the procedure. Unfortunately, the way it loads directly, I am not able to advance through it, and for the sake of time, I may skip through this part and bring it back at the end if there's interest. I'll let it play just for a few seconds. And this is the surgical team, which involves a group from Barosense, working along with the team of surgeons at the Université Laval, Dr. Simon Baron as the principal investigator up there. And this is here where the endoscope is basically introduced into the stomach, retroflexed, and the distal element of the device is used to create a plication through which the anchor will be later inserted. There's sort of a animation in the on the side. So you create the suction effect to make sure you have a full thickness piece of the stomach through which you're going to place this anchor. The issue, of course, with partial thickness is the concern about detachment. Okay, now I'm going to skip through the video. Operative time, as you can see here for the patients involved, these are the patients listed in sequence. On average, it was about 200 minutes, and you can see as we proceeded, as the group proceeded with the study, their times improved. Post-operative data, or the follow-up course, involved having the patient stay in hospital, having an upper GI swallow, and then they were discharged when they were tolerating liquids. No complications had to be present prior to discharge, and the patient would have minimal to no pain. And these are basically the results. The BMI before and after the TERIS procedure. As you can tell, at baseline, we have an average BMI of 45, 42. And then at 6 months and 12 months, we have the results reported there. We see about basically a 9-unit drop in BMI between baseline and 6 and 12 month follow-up, which is statistically significant, but there's no difference between the 6 months and the 12 months results, as you can see. Safety data, there are no mortalities. One patient had to be converted to open surgery on the same day. The device was later modified to allow us to bypass a certain issue we had with creating the plication at the time. Since that was done, there were really no need for any conversions. There were 5 events of device clogging with food, and this was basically solved endoscopically without having to remove the device. Tearing applications listed as 20%. Each patient had about 5 anchors, so we're calculating out of the total number of anchors in the 12 patients, about 20% of these anchors led to some sort of detachment. And over time, over a course of about 10 months, we had about 5 patients exit the study, and this was basically completely on a voluntary basis. So in conclusion, the study, basically it is feasible to do this procedure. So far the results are looking very encouraging. What we want to highlight, the efficacy involved, is that we did see a significant drop in BMI over the 1-month period. It is, however, it does raise question as to what role this procedure will have in the future. Is it temporary or permanent approach to a problem? And taking in mind the modifications that will be needed, or that have been done, or will continue to be done over time to enhance this further and further. Thank you for your attention.